Causes of sciatica. In this video, we'll talk about perhaps the most common cause, disc injury. Contrary to what most people believe, sciatica is not a specific diagnosis per se. It refers to a description of symptoms created by any inflammation of the sciatic nerve and its branches. Mechanical pressure anywhere along the length of the sciatic nerve can create varied intensity of radiating and at times electrical pain that may be accompanied by sensory disturbances, such as numbness and tingling, or motor deficits in the form of weakness. Disc injury occurs when forces imparted on the disc supersede its ability to tolerate loads, resulting in tissue failure. The disc acts like a hydrostatic structure when compressed either by the weight of the body, the contraction of the surrounding musculature, or via impact. The nucleus pulposus becomes pressurized and displaced. Through hydraulic forces, the displacement of the nuclear material creates lateral bulging of the annulus fibrosus and vertical bulging of the associated vertebral end plates. This deformation of tissue can create injury. With high enough compression or with repetitive subthreshold compression cycles, failure of the vertebral end plate can occur, creating a crack in the cartilage and the underlying bone. The most commonly recognized disc injury is a disc herniation that herniates posteriorly. This injury occurs when the nucleus pulposus focally prolapses its way out of its normal central location in the disc through the annulus fibrosus and beyond. Biomechanically, a combination of spinal compression and flexion frequently is the culprit, especially if the lumbar spine is approaching full flexion and if this movement is performed repetitively. In this scenario, the nucleus pulposus becomes pressurized and pushed posteriorly. Adding twisting or lateral flexion to the mix places more stress on the disc and directs the migration of the nuclear material. So if the spine is compressed, flexed, and turned to the right, the likely direction of herniation is in the left posterior lateral direction. The presence of shear forces compounds the problem because it adds even more stress to the picture. As the nuclear material pushes towards the annulus fibrosus, it can rupture right through while under high loads, or it can delaminate the fibers of the annulus with repetitive flexion and compression cycles, breaking the bonds between the fibers, and allowing the nucleus pulposus to seep its way radially through them. There are three main types of posterior disc herniations. A disc protrusion is a herniation that is still fully bound by the annulus fibrosus, but has a focal deformity which, if large enough, can create nerve injury. A disc extrusion involves a larger amount of herniated nucleus and a full break through the annulus fibrosus. Once the nuclear material breaks off from the disc space and is sequestered within the spinal canal, it is considered a disc sequestration. The mechanical pressure of the discal material against the nerve root, the chemical reaction from the injured tissues, or the actual contact of the nuclear material with the nerve all can contribute to the inflammatory cascade that results in nerve pain. Location of the herniation is important, and the most common of these is a paracentral disc herniation. This is located here in the lateral recess of the spinal canal, just medial to the neural foramen, where the posterior longitudinal ligament is deficient. As you can see in this model of a left paracentral L4, L5 disc protrusion, the L5 nerve root is compromised. The L4 nerve root is not affected as it has already left the spinal canal through the L3, L4 intervertebral foramen. This injury will likely cause moderate to severe low back pain associated with pain down the sciatic nerve and its derivatives.